Okay, screen visible to everyone?
Yes, sir.
Okay, so shall we start?
Yes, sir, we can.
Okay, so today we'll be discussing about antenatal care. So let's begin. Okay, so it's a very important topic. So, what is antenatal care? So, basically, this is a care that we provide women during pregnancy. Okay, it's a simple. Normally, I think those who are posted in the gynae they have seen the patient coming to the OPD, you know, and we ask the patient how she's doing, how is the pregnancy so far, and we do examines. Okay, and then we give advice. So basically, that is antenatal care. Okay, and it is also called the prenatal care. So these are basically we ask the patient to visit regularly. Okay, in a periodic fashion. Okay, so it depends upon the protocol. So WHO they have now recently modified total 8 visit. Okay, so in case of RCOG, it depends. For nulliparous, around 10 visits, and for multiparous, around 7 visits. Okay, so it depends upon the protocol, how frequently the patient needs to come for the antenatal care, and it should be modified according to the need. If the patient develop complication or if the patient has some comorbidity, let's say she is having diabetic. Okay, she is the known case of diabetes for let's say 5 years under insulin, then she may obviously need frequent visits. Okay, so it should be tailored according to the need as well. And this and actually this prenatal care it start before the pregnancy, okay, and end at the delivery and the postpartum. So ideally it also include the preconceptional care. Okay, so preconceptional care, that means to readiness for the pregnancy. Okay, to make sure that the patient is in the best shape before embarking on the pregnancy. Okay, so what we can do in pre conceptional care, if the patient come before, and in that case we can advise for the healthy lifestyle. Okay, healthy diet, exercise to optimize the weight. Okay, because increasing in the weight, obese patient or those with the BMI more than 30, they are at risk of developing hypertension, diabetes. Okay, clots in the legs and lung, that is venous thromboembolism. Okay, so this the pregnancy will be risk, and the study has shown even the congenital malformation, miscarriage, okay, and obstetric complications like PPS, shoulder dystocia, all those things are increased in the obese patient. Okay, so what we can advise the patient if she came in preconceptional care, yes, we can healthy diet and exercise, okay, and to optimize the weight. Other what we can do is a correction of any pre-existing disease, just like such as epilepsy. Let's say, just take an example of epilepsy. For instance, if the patient is taking valproic acid, okay, sodium valproate, and it is teratogenic as we know. Okay, so as I 10% of the baby may develop the congenital anomaly. Okay, maybe neural tube defect or facial abnormal facial cleft palate, cardiac defect. So multiple anomalies. Okay, so if the patient came in preconceptual care, what we can do is we can switch to the more safer alternative. That is maybe levetiracetam, okay, or Libera. These are new drugs, okay, like lamotrigine, and they are better. The research, okay, the studies have shown that they are better than valproate. So this is just an example. Okay, so we can switch to more or better alternative. If the patient is hypertensive, maybe she is taking enalapril or losartan antihypertensive data, and these drugs these are not safe in pregnancy. So what we can do in preconceptional care, we can switch to more safer alternative like nifedipine, okay, labetalol, like that. Another is prompt diagnosis of pregnancy. Okay, so another component of antenatal care is a prompt diagnosis, because once we diagnose the pregnancy, then yes, if there is anything we need to optimize, so we can optimize even in the early pregnancy as well as, okay, but we have to do bit aggressively, but we can do that at that point as well. Okay, and let's say patient is the known case of hypothyroidism and just she diagnosed. Okay, so prompt diagnosis around 5 weeks, 6 weeks, then we can start the thyroid norm. We can again send the thyroid function test, and we can start thyroid norm. Okay, bit in the higher dose. Okay, so prompt diagnosis also helps us in the optimization as well. Okay, it has a role in optimization. and so that we can ask the patient for a more frequent visit. Initial antenatal evaluation. Okay, so what we do basically in the OPD. Okay, so basically in the OPD, what we do first, we take history. Okay, we first take history, detailed history. Okay, how is our pregnancy so far, any issue, any nausea, vomiting, any abdominal pain, any PV bleeding. Okay, so we ask this, then we take a thorough history. When was her last menstrual period, to confirm her date. Okay, it's cycle regular or not, any issue with during the cycle, any clot, excessive bleeding, painful menses, all those things you ask, and obstetric history. Okay, so is this her first time she's being pregnant, or uh, what about the other past pregnancies? Okay, everything you need to ask in detail. Was she using any contraception? Okay, so those things I think we have discussed in, we will discuss in tutorial as well. Okay, so detailed history and examination we have to take. Okay, and routine investigations, there are certain investigation, okay, which we do routinely, and there are certain special investigation for selected patient, and we give advice. Okay, so basically this is the basic antenatal evaluation, and this is the core. Okay, this is the crux of the antenatal care. And follow up, independent, it is tailored as per the patient need. Okay, okay, so let's discuss what are the aims and objective of the antenatal care. Okay, so aim, what is the main aim? Okay, so basically these are the aims. Okay, what are the aims? One is to screen for the high risk condition. Okay, each visit we ask the patient any danger sign. Okay, we ask the patient, we measure the blood pressure. Okay, so let's say, so measuring blood pressure means we are screening for hypertensive disorder. Okay, so we screen for the high risk pregnancy at each visit, or we try to ask the question that is tailored for if she is developing any condition, or if she has any condition. Okay, and the prevention of the complication if possible. Okay, so once we diagnose it, we can optimize by the multidisciplinary care. Okay, so we can refer, if it's a medical condition, then we can refer to the internal medicine specialist. Okay, so that early intervention can be done, and prevention of the complication if possible. Okay, so that at least we can minimize an early detection and treatment of any complication. Okay, so that's why we take a thorough history and examination to make sure, okay, if there is any issue, then we can optimize early. Okay, let's say if we develop, if the patient develop hypertension, maybe if we detect the high blood pressure, okay, hypertension in first visit, maybe around 6 weeks, 7 weeks, then maybe she was already, uh, she already has developed hypertension, but she was unaware. Okay, so in that case, what we can do, we can optimize. Okay, so we can prescribe some medication in liaison with the medical team. Okay, so that's why so aim is to detect early as well as, okay, to detect early, and the treatment can be started, okay, to prevent the complications, and it will obviously, it will minimize the complication. Then what we can provide is antenatal education. This is very, very important. Okay, and so we have basic information leaflet as well. Okay, and we do counseling verbally as well as written, in the written form also. Okay, so instruction about general hygiene, breast care, okay, nutrition. So what type of diet she should take, what should be avoided. Okay, that we can discuss. Okay, and birth preparedness, plan of delivery and possible complication, newborn care, future contraception. So basically we discuss everything. Okay, and psychologically, okay, the pregnancy itself is a new thing for some, most of the nullipara. Okay, and they may have, the change in the mood because of the change in the hormone. There may be change in the mood, they may feel down, depressed. Okay, so that's why psychological support is also important, and they may be apprehensive because, when they think about the labor delivery process. Okay, so what's our aim is this rapport building, to alleviate the fear. Okay, to make them strong that this is an physiological condition. Okay, we are here to support that, you should show support as well. Okay, so basically these are the aim of the antenatal care. So we screen for the high risk patient, we screen for any high risk condition each visit, prevention of the complication at the earliest, and detection as well as treatment at the earliest. Okay, antenatal education and psychological support. So what is our objective? Is our main objective is to deliver the healthy baby from a healthy mother, and ultimate reduction in the maternal and the perinatal morbidity as well as mortality. Okay. Okay. So since we discussed one of the component is one of the aim is to screen for the IRIX. So let's touch briefly. Okay. So this thing we again discussed in our tutorial as well. I think those who have been posting in the obstetrics posting, they have we have discussed this topic. So this is just briefly we discuss about the high risk pregnancy. Okay, because our main aim, it is one of the aim. Okay, one of the aim of the antenatal care is to screen for the high risk cases. So what is basically high risk pregnancy? Pregnancy with an increased risk of poor outcome for fetus and mother, or there is high chance of adverse consequences. Okay, and those pregnancy we call high risk pregnancy. Okay, so there are certain conditions, okay, which make the pregnancy high risk. Okay, that means there is increased chance of adverse consequences to either mother or fetus or both. Okay, and they require additional care and supervision. Usually these people may be managed in the multidisciplinary team. Okay, MDT. Okay, so it can be general. So we'll discuss one by one. Okay, so what are the general risk factor? If the patient age is less than 19 years, that is we call teenage pregnancy or young primary gravida. Okay, or young pregnancy, young pregnant lady, that is we call teenage pregnancy or young primary. Or if she's 35 years and she's first time pregnant, okay, she's first time pregnant, then we call elderly primary. So extreme of age, because young patient, she may not be regular to the antenatal care. We may miss the certain condition like anemia. Okay, there's high risk of uh, yes, young patient is also a risk factor for developing pregnancy-induced hypertension. Okay, and low birth weight, that is also consequences of young primary. And in case of elderly primary, so she's also vulnerable for developing medical conditions like diabetes in pregnancy, hypertension. Okay, increased chance of yes delay in conception, chance of miscarriages also increases with age. Okay, so that's why we categorize in the high risk. Height, if less than 145 centimeters, so short stature may be associated with a small pelvis. Okay, so outlet will be narrow, or that's why chance of obstetrical labor. Okay, so a grand multipara, what we call when she has delivered already more than 4 babies, then we call this grand multipara. Okay, so is now she's been pregnant. Okay, fifth time pregnant, and she has 4 children. Okay, or she delivered 4 babies, then we called it grand multipara. Okay, grand multipara. So grand multipara, they are at risk of postpartum hemorrhage. Okay, abnormal presentation, malpresentation, and this is the risk factor. Unmarried mothers, so likely she will get less support. Okay, that's why we categorize in the IRIX and IRIS negative blood group, especially if the father is positive and if the baby is positive, and that will be the high risk pregnancy. So other category includes the events during the previous pregnancy. So was there a repeated history of um, abortion, or more 3 or more consecutive abortion, previous stillbirth, previous preterm delivery, that delivery before due date, before 37 weeks, in fact before 37 weeks of gestation, or previous neonatal death, or previous anomaly. Okay, and history of fertility treatment, history of postpartum hemorrhage, retained placenta. Okay, assisted or cesarean delivery, and previous FOCI. So basically these things you will again encounter in individual chapter. Okay, but I'm just highlighting what are the risks pregnancy. Okay, high risk pregnancy, and because they have tendency to recurrence. Okay, so when there is recurrent pregnancy loss, again it can recur. When there is previous history of stillbirth, it can recur again. Previous history of preterm delivery, it can again recur. Anomaly can recur. Okay, so history of postpartum hemorrhage, it can recur. And when the patient had delivered by C-section, again she may have to go for cesarean delivery. Okay, previous macrosomic baby again. So these things can be recurrent. That's why we categorize these into high risk pregnancy. Okay, so medical condition, yes, this can lead to adverse consequences: hypertensive disorder of pregnancy, like anemia, diabetes, renal condition, liver disease, heart disease. Okay, if the patient is smoker, okay, alcohol consumer or drug abuse. Okay, so a smoker leads to low for gestation is baby. Okay, so baby sometimes preterm delivery or even intermittent fetal death. Okay, so alcohol, there are some congenital anomaly associated with alcohol. There is no safe level of alcohol in pregnancy. Similarly, drug abuse like cocaine, it can cause abruptio. Okay, premature separation of placenta. Okay, so there are consequences. That's why we categorize this thing in the medical condition. Okay, so these are the personal history. So these are not exactly medical condition, but these are from the personal history, and these are behavioral things. Okay, and severe malnutrition or obesity. Okay, so and these have their own consequences. So similarly, surgical condition like previous cesarean delivery or pelvic floor repair. Okay, or previous perineal tear repair, pregnancy with fibroid or ovarian cyst. So basically, these are the surgical condition and these has consequences. Okay, and even during the present pregnancy, if something develop in the pregnancy, again we categorize as a high risk. Okay, so patient can develop hypertensive disorder, that is preeclampsia, eclampsia, okay, or bleeding disorder. Sorry, bleeding during the pregnancy, which can be threatened abortion or antepartum hemorrhage. Following delivery, it can be postpartum hemorrhage. Okay, malpresentation, cephalopelvic disproportion, multiple pregnancy like twin, triplets. If there is excessive liquor, polyhydramnios or low oligohydramnios, if the patient is maybe is small for date or large for date. Okay, uh, if if the pregnancy has crossed the due date. Okay, so it's already post due date, more than 2 weeks post due date, that is 42 weeks post maturity, a pre-labor of the membrane, a preterm labor, if the patient is having severe infection, okay, like STD, HIV, septicemia. So all these are categorized in the high risk pregnancy. And okay, so so there are a lot of information. Okay, but don't worry. Okay, these are the individual topic, and you will be taught, okay, each and every topic individually. Okay, don't worry. Just I'm highlighting what are the high risk cases. The miscellaneous, if the patient is late booker or she is not regular to her antenatal care, less than 2 visits, history of blood transfusion, the chance of formation of RBC antibodies are there. That's why it is important. Short spacing, long spacing, and those total weight gain during the pregnancy. Okay, if it's less than 7 kg, chance of IUGR, or more than 14 kg, there are consequences. Okay, of the big baby, and congenital anomaly of the genital tract. So basically, there are a lot of high risk pregnancy. Basically, all the obstetrics. Okay, that is mainly what we discuss about the high risk pregnancy. Okay, so this is the major crux of the obstetrics. That's why do not get confused and do not get them. You may see a lot of information. Basically, we again will discuss. Okay, again and again all those topics. So just my aim today is these are the high risk cases, and we should be vigilant about those cases. Okay, so during the antenatal care. Okay, that's the basically main aim. So now let's discuss about documentation of care. So every time when we ask the patient to come to the antenatal visit, we have to document. Okay, we have to document, and documentation is very very important in case of not only in obstetrics, overall medicine. Okay, so this should be documented in a structured maternity records or handheld notes, and the patient should be provided with the notes. Okay, so we usually made a green card. So I think you have seen those who are posted in obstetrics and gynecology OPD. So you have seen the antenatal card. Okay, so we jot it down. Okay, about the patient issues or vitals, and then we give advice and everything. Then again we return those notes to the patient. Okay, so these are standardized national maternity record with agreed minimum data should be develop and use. Okay, or standardized national maternity record is also there. Okay, so government has also made it, but it's still yet to amend it. Okay, but maybe in near future they will modify it. Okay, so this is just one sample of the antenatal record book. Okay, so basically this is almost similar what we are using in Kish Medical College. Okay, so The first part is a patient particulars. Okay, then any risk factor. Okay, that's why we screen during the early pregnancy. Any risk factor we jot it down. Okay, the detail about the menstrual history, obstetric history, contraceptive history, medical history, any past history of blood transfusion or hospital admission, okay, surgical history, family history, personal history. So detailed history will take in and record in the pro forma. Okay, then we examine detailed examination, general as well as systemic examination and obstetric examination, and they are basic tests what we do. Okay, so like a routine test which includes hemoglobin grouping, platelet, okay, thyroid screening, TSS. This is commonly, not everywhere they do, but in our hospital, okay, in our protocol we usually follow this. Okay, thyroid screening for hypothyroidism, and glucose test, okay, OGTT or glucose challenge test, and viral serology like for hepatitis, HIV, syphilis, okay, and urine and stool. Okay, we also advice for vaccination during pregnancy. Okay, so diphtheria and tetanus, so 2 doses. Okay, and we document, and there is special investigation especially for those cases, maybe high risk cases or those with the condition, especially for the high risk cases. Okay, if the patient is iris negative, we have to send for indirect Coombs test. Okay, if the patient is a diabetic, we have to send for HbA1c, fasting, and postpartum blood sugar. Okay, if there is any liver issues and liver function test, so according to the patient, we have to send the investigation. So these are the special, and ultrasound. Okay, so dating scan, and at around 20 weeks, okay, 18 to 22 weeks, we send anomaly scan. Okay, so we'll discuss that thing as well, and we discuss about the patient regarding the plan of delivery. Okay, and if it's a vaginal delivery, or we may need to induce the patient, induce if she doesn't go spontaneously in labor, or elective LSCS, maybe those with previous surgery, previous cesarean delivery. Most of the time we go for cesarean delivery in our hospital. Okay, and we also discuss about the family planning. Okay, so it is also documented, especially by 36 weeks, patients should be discussed about the family planning. Okay, so maybe she has completed the family with the following delivery. In that case, we can go for permanent method as well, or we can discuss the temporary. Okay, so everything should be decoded in the structured maternity record. Okay, and at every visits, we discuss. Okay, we write the time, weight, is she perceiving fetal movement or not, any complaint. Okay, so vitals like blood pressure, and is she pale or not, any swelling of the legs. Excuse me. Excuse me. Okay, so we jot it down, and we measure the fundal height. Okay, so we measure the symphysis fundal height. Okay, so we measure symphysis fundal height, and we document in the centimeters. Okay, and what is the presentation? So is it a cephalic presentation, or is it a bridge? Okay, bridge or transverse lie. So we document it, and has the head engaged or not. That means the largest transverse diameter, biparallel diameter has crossed the pelvic beam or not. So we document here. Okay, in fifth, maybe 4/5 or 5/5. Okay, like that we document. And fetal heart rate. Okay, fetal heart rate we have to document. Then advice. So maybe continue the iron or calcium. Okay, so according to the gestation, we give the advice and plan. Okay, maybe rest, the physiotherapy sometime we recommend. Okay, so rest in left lateral position, like, okay, that advice we can give. And follow up maybe in the 4 week, okay, maybe in 2 week, so we can discuss accordingly, and we sign it. Okay, so this is the basic pro forma. This is the chart commonly we have in our hospital as well. And in the last phase, you can see there information leaflet. Okay, so basically, so in preconception, what are the things that need to be focused on? So it start with the preconception. Okay, so you can see in preconception, we have to ask, we advise for folic acid and certain things like diabetes, hypertension, okay, thyroid disorder, epilepsy, SLE, all these things should be optimized. Okay, so that should be in a best shape before embarking on pregnancy. Okay, then in the pregnancy, so what are the things, what are the do's and don'ts? Okay, so basically these focus on what are things she needs to do and what are the things she should avoid and when to seek advice. Okay, so these are things, so you can go through it. Okay, and especially we focus on the danger sign. Okay, so every visit we ask the patient, do you have any such issue, like if she's having pain abdomen, okay, on and off. So she may be give the history of certain glass of water. Okay, water may break, so she may give the history of, yes, certain glass of water per vaginum. Okay, she may give the history of bleeding, headache, blurry vision. Okay, decrease in urine output. Okay, she may feel like the pain over the epigastrium, excessive nausea, vomiting. Okay, and itching all over the body. All these are the danger signs because they are related to certain condition. Okay, so we have to counsel the patient about general. We have to give the general advice as well as the danger sign when to seek advice. Okay. And it includes during the labor, even during post delivery, and also includes the care of the newborn as well. Okay, so let's discuss briefly about how frequently we ask the patient to come for antenatal appointment. Okay, so conventionally, okay, according to the American College of Obstetrics and Gynecology, so every 4 weeks till 28 weeks. Okay, so every month till 28 weeks, then every 2 weeks till 36 weeks, then every week till 41 weeks. Okay, so basically this is the conventional schedule, but here is more supervision. Okay, so it requires almost 14 visits if you start from the 8 weeks. So you can count it. Okay, so from 8 weeks, if you count, it will be 14 weeks. So it will be many more frequent visit. Okay, so it is tendency of detection of the high risk cases will be there in case of these type of schedule, conventional schedule. But the drawback is sometimes in case of busy hospital, it is difficult to give time. Okay, so that's why if we reduce the number of routine appointment, what we can give, so yes, the more time per appointment can be given. Okay, and information and support can be provided. Okay, so it depends upon, so we can tailor it according to the need of the patient. Okay, but what about recommendation from Royal College of Gynecology and Obstetrics? So it's from the UK. Okay. Here, for the healthy, uncomplicated pregnancy, so it is 10 appointments for nulliparous and 7 for multi. Okay, so now the visits are few. Okay, in case of RCO, as per RCOG, the visits are a bit few. Okay, so that we can give more time each appointment, information and support. Okay, so but it should be decided and the protocol should be made as per, okay, in discussion in the hospital, because in some hospital they are less busy, so we can go with this protocol. Okay, when they're in the busy schedule, we can go with RCOG or WHO protocol. Okay, so basically in our hospital KIST we follow this protocol. Okay, so in KIST we follow the ACOG protocol. Okay, remember, okay, so WHO in 2016 it has modified the number of appointment. Okay, so previously we used to say visit, so now WHO suggests better to use the term contact. Okay, so visit is basically for when you go to certain area to visit, like zoo for recreational purpose. Okay, so that's why WHO advised not to use the term visit, better to use the contact. Okay, so antenatal contact, so total 8 contact. Okay, so contact 1, 2, 3, 4, 5, 6, 7, and 8. Okay, so total 8 contact, if not delivered by 41 weeks, should be decided accordingly. Okay, so this is according to WHO 2016 model. Okay, I think in last time your senior get question from, they got question regarding this new antenatal care model. Okay, so remember total 8 visits are there. So previously there were just 4 visits. Okay, 1, 2, 3, 4. Now we call it contact and total 8 contacts. Okay, so in first trimester at least 1 contact should be there, okay, up to 12 weeks. And in second, 20 weeks and 26 weeks. Okay. Then more frequently, okay, more frequently in third trimester. So 30, 34, 36. Okay, so and after 34 weeks, every 2 weekly, okay, till delivery. So let's discuss basically what we do, okay, as per WHO, what we basically do in each visit. Okay, in first visit, we confirm the pregnancy, we inquire about any issues, okay, like excessive vomiting, danger sign, PV bleeding. We inquire about the pregnancy, how is the pregnancy so far, how is she doing, okay. So we ask, okay, we inquire about the issues, okay. Especially in first trimester, we focus on is she tolerating fits, is she unable to take down things, okay, is there any excessive vomiting, does she or is she noticing peritoneal bleeding or abdominal pain. So this we need to inquire, and we do general physical examination. We measure the uh, body mass index, okay, and blood pressure, and we supplement the folic acid, okay. So recommended dose is 400 mcg folic acid. When we screen for asymptomatic bacteriuria, okay, like urine RE and urine culture we usually send, and we screen for the severe anemia, okay, severe anemia, hyperemesis gravid, excessive vomiting during pregnancy, okay. And we give general advice as well as, and we send the investigation, okay. Regarding the advice, we'll discuss, okay, in shortly. What are the investigation in first visit? Hemoglobin, platelet, okay, blood grouping, thyroid screening, TSS, thyroid stimulating hormone, serology like HIV, HBsAg, PDRL, okay, urine and stool, and ultrasound. So what is the aim of ultrasound in the first visit? To check for viability, okay, is the fetus viable or not, okay. And dating, we try to correspond, if the cycle is irregular, then we have to make sure the dating is correct, okay. So to corroborate with the finding for dating scan, we do ultrasound, okay. And chronicity, if the multiple pregnancy, to look for chronicity, number of the placentation, okay. And early anomaly scan, so gross anomaly can be detected in early, okay, around 11 to 14 weeks. We can detect the early anomaly as well, like an anencephaly, okay, or gross anomaly can be detected early, but full anomaly we have to do at around 20 weeks, okay. Then nuchal translucency and the nasal bone, okay. So basically these are aneuploidy screening for Down syndrome, okay. So we can also do at around 11 to 14 weeks. And antibody titer for RS negative patient. So these are this is the special test, okay, and these are relatively routine test. In second trimester, around okay, so 20 weeks we ask. So what we offer, we usually offer DT injection, okay, vaccination, iron and calcium, and routine care, and we advise for the anomaly scan, okay. So thorough, we look for any developmental abnormality, okay. Then in subsequent visit, yes, after 4 to 6 weeks gap, we can give second dose of the vaccination, continue iron calcium, we inquire about any issues, okay. And we do, yes, glucose challenge test, diabetes screening for gestational diabetes mellitus, okay. We screen for gestational diabetes mellitus at around 24 to 28 weeks, okay. So basically around 26 weeks we screen gestational diabetes, okay. And if the patient is anemic, then we have to send, we may need to send hemoglobin and, urine routine as per the patient, okay. And antibody titer if the patient is RS negative, okay. Then in subsequent visit, again we ask for any issues, we supplement iron and calcium, okay. And if it's needed, okay, for growth and it as for the patient, discretion, okay. If we feel like the patient is not growing, okay, the womb is not uh, appropriate for the gestation, okay. If it's small for gestation age, the uterine frontal height is less than expected, then in that case we have to send for, yes, ultrasound, okay. So growth scan. And at term we may have to send ultrasound for amniotic fluid volume, okay, liquor volume, weight, and placental location as well. And if patient is not delivered by the 8th contact, then we may have to offer induction of labor, okay. So basically we induce at 41 weeks of gestation after the 1 week of due date, okay. And before induction, we do admission, routine investigation, and okay, we do a bishop scoring for favorability of the induction of labor. Okay, and induction of labor, there's a special separate topic. Okay, regarding the induction of labor. In that case, you will discuss those things. Okay, so now let's discuss about the advice. So basically, at least 8 contact as per WSO we discuss, and so we discuss about we need to inquire certain things, we need to examine the patient, okay, and we have to send certain investigations as per the visit. Okay, and what about the antenatal advice? Okay, now let's talk briefly about antenatal advice. Despite we have though we have discussed about basic antenatal advice in the patient information leaflet as well. Okay, so I think I'm running out of time, so if I get disconnected, then again rejoin. Okay. Okay, so let's discuss about antenatal advice. So we give general advice. So at every visit, we give the general advice regarding the diet, exercise. Okay, what are the things, what are the do's and what are the don't do's, and what are the red flag signs like bleeding, PV. Okay, decreased fetal movement, swelling of the legs, face, headache, blurry vision. Okay, abdominal pain, leaking at the fluid pore vaginum. Okay, fever, rigor, excessive vomiting, diarrhea.